academic excellence and research at our institution. He has authored over 50 publications in PubMed Scopus, Web of Science Index journals. His Google Scholar metrics are 1,320 citations, H index of 16, I10 index of 20. Currently, he is serving as an editor member in World Journal of Pediatrics. He has received grants from national funded projects like BIRAC, Government of India, and served as a speaker at numerous national and international conferences. Additionally, he has contributed chapters in books and holds several copyrights. Dr. Karthik Babu S. is also registered PhD guide at the Tamil Nadu Dr. MGR Medical University. Recently, he was honored with the Best Researcher Award 2024 by the Health Minister of Government of Tamil Nadu, recognizing its outstanding contributions to the field. Please join me in welcoming Dr. Karthik Babu S., Principal and Professor, KMCH College of Physiotherapy, for the inaugural address, and followed by a talk on why, what, how of outcome measures. Over to you, Principal Sir. No. Good afternoon, everyone.
Good afternoon, sir.
Good afternoon, sir. Am I audible, I believe?
Yes, sir. Audible.
On behalf of KMCH College of Physiotherapy, I welcome each one of you for this FDP program, Faculty Development Program. So I'm just going to give an overview about what, why, and how of outcome assess in physiotherapy research. So the team consists of the faculty members from Physiotherapy College of Physiotherapy College. So this team consists of professors, associate professors, assistant professors within physiotherapy stream, as well as the biostatisticians, anatomists, physiologists, and clinical psychologists. Yeah. So just we started off with one of its kind to start FDP program, particularly on outcome measures. For the fact that we believe that outcome measures are critical and essential in physiotherapy research. In fact, we wanted to have a program that is of pedagogy and research methodology. And then we realized that this is important for postgraduates as well as entry-level physical therapy. So we came up with the concept of outcome measures in physiotherapy research. So where we mainly cover the outcome measures in three specialty domains: neurological physiotherapy, cardiopulmonary physiotherapy, and musculoskeletal physiotherapy. But
not limited to these domains, but of course the outcome measures are very vast, and it's widely used in physiotherapy research and other streams as well, gynecology, pediatrics, and sports arena. But considering the nature of FDP, for 2 weeks, we limited the measures in three domains. Right. See, what is outcome measures, and otherwise called outcome measurement instruments? So in clinical use, basically we use them now and then. Sometimes when somebody asks you about how is patient doing, we simply say patient is doing good. Slides. Okay, what is the
இந்த ஸ்லைடு எங்க இருக்குன்னு பாருங்க, அங்க போய் ஷேரிங் ஆப்ஷன் இதுல கொடுங்க. மேல
move outline
ஸ்லைடு ஷேரிங் ஸ்லைடு ஜூம்ல வரல.
Okay.
இல்ல அங்க போங்க, அந்த ஸ்லைடுக்கு போங்க. ஸ்லைடு ஷோ கொடுங்க. ஸ்லைட் ஷோ கொடுத்துட்டு அந்த பேஜை வந்து நம்ம இதுல வைக்கணும்.
Okay, no. Sorry for some of the technical glitches. I believe the PPT was not shared. Some of the delegates said it was not viewed enough. Yeah. So as I said, most of the time we say patients are improving or patients doing okay. But ideally we have to quantify the kind of status that patient has, the features, in other words, the improvement. So basically, an outcome measures are very critical to quantify a construct that we are measuring. The constructs could be motor functioning, walking, balance, anything and everything. We need to have a certain tool to measure it. So that's where outcome plays a vital role in clinical practice. So in other ways, it's called outcome measurement instrument. The next question comes: who can use the outcome measurement instruments? And there is a notation that in academia, faculty teach outcome measures. In a clinical practice, most of the time we do use, but considering the time constraint, we don't pull out some outcome measures. Basically, outcome measures can be used by every physical therapist. So it could be an academician or a clinician who practice patients, as well as the postgraduate students. Undergraduate students can use, but they may not have a full knowledge about when to use these measures and what to use. See, outcome measures and research. This is again a myth or a misbelief that the researchers use these outcome measures only during the dissertation or a thesis. So whenever you come up with a research topic and you are asked to find an outcome measures, so it's not that way. See, outcome measures should be used during every encounter that we have with the patient. Actually, what are the challenges in using outcome measures? Why don't we use outcome measures? We say, as I said before, patient is walking better. You ask how is patient doing? Is yesterday patient walk well in a parallel bar. Now you are making the patient walk outside the parallel bar with some kind of a support. So this is the description we say. Of course, this is okay. This is a qualitative kind of measurement that you say based on your visual interpretation, based on an assumption. You say patient is doing good, but you have to quantify about the patient's status of the actual construct, the outcome measures. That's where it plays a role. What are the challenges? Of course, I'm not going in detail about why can't we use outcome measures because the fact that we don't have an outcome measures. We don't have this particular tool available. I'm not talking about it. Every clinical outcome measurement is available. Most often it is freely available. We can gather this from a database. Even it is copyright protected. We can write a mail to the developers and they share with us. But the challenges doesn't lie in accessing the outcome measures. At some instances, we don't have sophisticated equipments that measure the construct. For an instance of photography, EMG, we don't have those devices. That is a limitation. We don't require all the time the sophisticated outcomes, but ideally we have to use them. But what are the challenges? Or in other words, we say difficulty, but what are the challenges we face not using the outcome measures? The first thing comes about the syllabi, the curricula. The curricula should emphasize the use of outcome measures. It's not mentioned, then we don't use. The mentors don't give an importance to understanding the outcome measures, what is available. We don't aware about them, when to use, how to use. That's the major problem that we face. Why the postgraduates or entry level physical therapists are not using. Of course, the capacity itself, capacity and infrastructure as such. So we need to have the tools available and the space available to administer this, plus the clinical facilities. As it's the health profession, physical therapy is a health profession. We deal with patient care, and ultimately we need to have the patient flow to administer them in an actual scenario. We don't have patients, then there is no reason to use them. So we need to have patients to use them. And on the other hand, whenever we have a patient of interest, we should think of using these outcome measures. We have to have the curiosity, interest to use these outcome measures. In a lot of work settings, we complain of workforces. We don't have sufficient workforce, and the time is insufficient. Do agree, but considering the volume of patients that we have and the workforce available, we should start using these outcome measures. So we have to find time to assess the constructs, and we start using these outcome measures. Right. Science is not a belief, but a will to find out. So that's how the science works. So everybody is scientist. Whoever gets involved with patient care and start using these outcome measures and evaluate the patient, and so this is the finding that you see. So everyone who start using these outcome measures and do evidence-based practices as scientists. So scientists or investigators, but it is not limited to the postgraduates who perform a thesis, or undergraduates who perform a project. Everyone, we are the clinicians, should understand the current level of evidence available and use these outcomes tools. So scientists, investigators, whoever use these tools, consider as scientists, investigators, this is basically a kind of professionalism one shows. We need to have interest to do this and right way of approaching the science. That is more important. In the science, the execution of science and research lies within the scientist and investigator. So we need to be more loyal and ethical, and so the professionalism to do this particular research. And there is no compromise in conducting the research, because if we try to compromise the research, then the statement of the science is not belief is also compromised. So we need to do research with an utmost dedication and passion, and so consistency, and kind of the interest and curiosity to execute it. Right, and these terminologies we are familiar with: dissertation, thesis, and project. Most of the time, this is time-bound research, particularly when it comes to undergraduate project or postgraduate thesis. The candidate should complete this particular work within the time span, and many institutions, universities ask to submit 3-4 months before, and then you will have just 1.5 year time if it is a 2 years program, and you start off this project by end of first year, and hardly you left out with 6 months, and then you begin data collection. Then by then you do a couple of months time, by then it's done. So probably you would come up with well structured research question, but ultimately one cannot execute that particular research due to time constraint nature. Then what would happen? The data fabrication would happen, and a small number of data become manipulated into multiple numbers. Then we are not actually testing the research question. That particular knowledge is not going to be helpful to researcher or the reader who read that particular work. So it is not of no use. So we need to be very cautious about picking up a research question and use of these outcome measures in a specific science. So the project is a small scale study. It may not require an original research. Maybe in my personal experience in one of these scenarios, I happen to see nearly 90% of the studies from undergraduate students are randomized control trial. It is impossible to do a randomized control trial at an undergraduate level as well as in the postgraduate level, and having a randomized control trial in a postgraduate, it's waste of time and waste of resources, and it is impossible. So we need to see to that when undergraduates need not to generate something new. The undergraduate would replicate something that is available, and the students would know how to step into a research. So it is basically about the understanding about the research, understanding. So that we basically ask the students to do a literature search of a specific construct. It could be a balance. We can ask them to read about the physiology of balance and pick up one scale. It could be a work balance scale. Read about the work balance scale and administer in a couple of subjects. That's enough, because the undergraduate student is not going to generate something new. So giving a randomized control trial or giving a study that requires 2-3 years of time is of no use. Similarly to the postgraduate dissertation, postgraduate thesis, and we would say dissertation. We alternately use dissertation and thesis. Any presentation of a learned or existing information is basically a thesis. That's it. Something you need to develop a new concept and analyze based on the research findings or what you have seen across a time period. That's the dissertation. So it is basically whether you are replicating something that is existing or you are finding something new. So this is where the question comes and the use of these outcomes come. So it all depends on the time. So how much of time a researcher have. and what kind of interest and passion the researchers show to execute the research question. So this is where the research outcome lies. This is where the utility of these outcome measures also play a vital role. And the idea of this FDP program is to mentor or to give a little bit outline about what kind of an outcome measures can be used in physiotherapy research are meant to use. So that's the focus. And in general, the research can be of two kinds. It's a quantitative research and qualitative research. Qualitative research is you don't have the number in a qualitative research. It can be a simple observation from a patient. In fact, it can be a case study. There are many forms of research design under qualitative. A simple example is case study. You find a unique presentation in a case, and you wanted to follow that case for 1 month or 2 months, and then you take a outcome measure. Of course, it has a data, but having a data from one patient is not actually conveying a quantity. So that's where you say qualitative. So, or you take an video image of a patient walking, and you show that patient walking after 2 weeks of rehabilitation, and see this is the change that you observe. These are kind of a qualitative research. Quantitative research is nothing but you manipulate the data, you collect the data and use the data to derive some conclusion. You do some kind of analysis and you report them in a descriptive form as mean, standard deviation, or proportion. Right? So these are the research that we do. And besides that, these are the 4 types of research that is there. Exploratory research that is basically to gain a familiarity within the phenomena. Descriptive research and diagnostic research and hypothesis testing research. These are the 4 categories. But what we in general do is an intervention study and observation study. This we are familiar with. Observation studies, where we have 2 kind of studies. One is just descriptive. You collect the data at one time point and you present the data as it is in proportion. You have a sample size, so you have a proportion. It is measured in a percentage. You don't do any analysis. It's a cross-sectional study. In other kind of a study, it's a cross-sectional study, but you do some kind of an analysis that you have a casual relationship between 2 variables. You take 2 variables, for example, of balance and walking. So you want to find the ability of balance in a patient who has undergone a hip arthroplasty. At the same time, you have to measure the speed at which the patient walks post TKR. So you want to find a strength of association between these 2 variables. One, speed is a variable, and other one is the balance is a variable. So you want to find the strength of association between these 2 variables. Then it's a correlation study. It's a correlation study, right? Analytical study. You are trying to analyze the strength of association between 2 variables. But here you don't know whether if the balance is influencing the walking speed, or walking speed is influencing the balance, because there could be other factors that is not tested for. It could be the muscle strength, or it could be the range of movement, it could be the pain in the particular subject could influence walking or balance. So this is the drawback of cross-sectional study, when you find the strength of association. In fact, you wanted to find what determines the walking speed, then you have to have all the variables as a dependent variable, and then you measure the independent variable. This is also kind of a cross-sectional study. Only thing, you do a different kind of statistics having all these variables. When you find a strength of association, use a Pearson correlation analysis, that's a method in R, and you want to find what variables, what dependent variables that strongly influence the independent variable that's of a speed, then probably use a stepwise multivariate linear regression analysis. So then you can say how much of a contribution are X and Y variable attribute to the independent variable. So this is the cross-sectional study of an analytical nature. And then intervention studies. Straightway, we go randomized control trial, because it's commonly seen and commonly we hear randomized control trial. So we have two groups and we start doing randomized control trial. So randomized control trial is something where you test the hypothesis. So it is not that much easy to do at a postgraduate level. So randomized control trial is done at a doctoral dissertation level. So there are other forms of other forms of intervention studies where you need to find effects, benefits of an X intervention. Right? You assume that this intervention, this way of treating a patient would be beneficial. You can start off a single group pre-post intervention study, have a variable, an X variable, and use that outcome measurement, and take 10 subjects, more than 6 subjects, more than 6 and less than 10 you do for a pilot study. Then you come up with the mean standard deviation. That mean standard deviation will help you to determine a sample size for a future study. Where we should not pitch into a randomized control trial. Then there are other forms of designs, the non-randomized control trials are there. So there are so many forms of research designs are available. So where we wisely use these outcome measures. Right. Fine. See, outcome measures. I'm not going to deal much about the psychometric properties of these outcome measures. The next speaker, the biostatistician, would deal with all these variables. But however, I'll just throw light on these variables. Whenever you pick up a tool, outcome measures in the physiotherapy research, you have to see to that whether the psychometric properties of these tools been established. These are some of the commonly tested psychometric property measures: reliability, internal consistency, validity, responsiveness, sealing and flooring effect, measurement error, minimum detectable change, and minimal clinically important difference, otherwise MCID. So you look for this. So then probably even simple matter, you take a work balance scale, then you have to pick up the articles of psychometric properties of work balance scale. See whether the reliability been established, the validity been established in a population of your interest. So what is the responsiveness? How much of the change is acceptable? So we need to go and see the established psychometric properties of an outcome measure. Then only you have to think of using that outcome measure in your clinical practice or in the research. We cannot pick up an outcome measure and can't administer. That's where these points come into play. Reliability, yes, it is not the first one that you test, but reliability is the commonly known. Everybody knows this. It refers to consistency of a measurement. A researcher take a work balance scale today and scores 40 out of 56, and the researcher take the outcome measure after a few days when the work balance scale is not supposed to change in that criterion. Take this measurement after 2 days. The testers should able to reproduce the same value. Then the observer is reliable. The tool is having a reliability. Internet reliability is something where two observer measure the outcome measures at a different time point and see whether both could produce the same scores. And we commonly say reliability in the research. What is the reliability in the research? It's not something relate to reliability of an outcome measure per se. Any research that we take, any research finding that we able to find, when you read through the methodology, we should be able to reproduce. Suppose we conduct a similar kind of a work here using the same outcome measure, we also should be able to produce a similar kind of research. Then the particular research is said to be reliable. We say reliability in a research. So basically, whether the research method can reproduce the same results, that's what the reliability means here. And one more thing comes about internal consistency. Internal consistency is somewhat related to this reliability. It is about how well a test measure or assess what it is intended to measure. It could be a test, or it could be a questionnaire, or it could be a survey. How well this particular test assess what it is intended to measure, that is the internal consistency. It is basically a correlation among the several items in the same scale. You take Berg balance scale, you are familiar with that. It has 14 items, sitting, sit to stand, then standing, feet closer, eyes closed. These are the items. How well each item is correlated within the items of the same scale. That is what about the internal consistency. It is measured in Cronbach's alpha, Cronbach's index, where you see whether several items that measure the same construct produce the similar score. That is what about the internal consistency. Right? We need to see to that whether internal consistency is established for a scale. What is construct? We are just repeatedly using about construct. Construct is nothing but a theoretical idea or theoretical concepts that is derived from an empirical observation. For an instance of balance, we think about balance. Every physical therapist know about balance, right? And what is balance? Everybody would view balance in a different way. Suppose we think of a construct of a balance, we see balance is ability of maintaining the center of mass within the base of support. We think that way. We are just talking about a steady state of a balance, right? It's about a steady state of a balance where we don't consider the dynamic nature of a balance. Suppose you think about the dynamic nature of a balance, then we think of anticipatory balance control, reactive balance control. Then you require a different tool to measure this particular construct. Sometimes you think of a balance from the point of the role of sensory system, eyes closed, standing on a foam. Yes, then you think of a different construct. That's where we have many tools. Not every tool measure everything. So you have a tool that is validated, and it should measure what it is intended to measure. That it should measure what is the construct that you intend to measure. So the validity, when it comes to validity, it is about the tool that has how well it could accurately capture what is intended to measure. That is what about the validity, right? So we need to think about a construct whenever we take an outcome measure. We have to think about construct. It's otherwise called construct validity, to an extent to which a test accurately assesses the theoretical construct. Then there are different forms. I'm not going much in detail about this. Criterion validity is otherwise called predictive validity. For example, someone who is an acute stroke, who is in the bed, finds difficulty in rolling over on both sides and getting up. Basically, you measure the bed mobility or a trunk control of the particular patient. Well, whether he can able to sit independently for 10 seconds. You see that not all the patients have this. Someone who has better sitting balance ability or a trunk control, measured in trunk control test, shows a better standing ability at the time of discharge, or ability to walk is better. Someone who has better balance, better trunk control test score has better ability to walk, or walking speed is better. So this is the criterion validity or a predictive validity. A construct of run control test is predicting the walking ability of an individual. So this is one. And content validity is nothing but how well an instrument covers all the relevant parts of the construct it aims to miss. So then, said inconsistency, the measurement error. What is measurement error? Measurement error is the difference between the actual value of a quantity and the value that you obtain through the measurement. So that's the measurement error. Why we need to consider measurement error? A tool can be reliable. Tools validity being proven because it actually measures the construct. But what if the assessor is not trained? The assessor doesn't know how to collect the data, how to use this outcome measure. Then that's where the measurement error comes. So measurement error is the difference between actual value of a quantity and the value that you obtain through the measurement. So that's where you need to train for collecting the outcome measures. So in a postgraduate study, when you say you are conducting an X intervention and measuring an Y outcome variable, and you think that the Y outcome can be blinded by your postgraduate, then you have to train the postgraduate on how to take this outcome measures. So that's where you minimize this measurement error. As I said before, what is construct? It's about, for an example of balance, we don't use the terminology of static and dynamic, because balance itself from a physical therapist point of view dynamic. It doesn't mean that the scale that you use static doesn't have a significance. But we view a balance in a different construct, an act of maintaining, achieving or restoring a state of control during any pose or an activity. That means you define balance, you describe balance into a steady state and proactive, reactive balance, right? So something that also we have to take into consideration whenever we use this tool. Sometimes we need to use a lot of performance assays. It's nothing but an isolated core motor execution capacity tested outside the functional context. Right. So, so this particular paper is of usefulness, it's of use for those who are working with patients with neurological conditions, particularly in a stroke. This particular paper is about what outcome measures to be used for measuring balance and mobility within 6 months post. One of the consensus group who has given the recommendations about when and what measures to use, particularly in a stroke patients. Right. So balance measures, we are familiar with the bed balance scale. Bed balance scale has a maximum point of 56. Now, just think about what if patients who score the maximum point of 56. So that means you have a chronic case, or you have a late subacute stroke patient who score 56 out of 56 in the balance measure, the measure using bed balance scale. That means patient's balance ability is complete. But the scale doesn't have a capacity to pick up the balance deficits that patient has an underlying feature. So that's where the scale has a ceiling effect. So we cannot use the bed balance scale in people who have a balance issues but high performing individuals, right? So what is recommended? Usually the bed balance scale is used. Bed balance scale is used in an acute care setting. But in general, what is recommended to use is the mini best test. Mini best test has these 3 domains: that steady state, balance, proactive, reactive balance, and you take the Vestas tool, it of course it measures the mobility also, and it measures the sensory orientation, role on organization, role on balancing, biomechanical constraints. But what is recommended in a clinical practice is to use the mini Vestas, to use mini Vestas always, and consider the functional ambulatory category. So this is the categorical scale. Someone who score functional ambulatory category stage below 3, then you include work balance scale. So what that means, what is functional ambulatory category 3? Which means someone who is ambulant in an even surface, but requires a manual support or requires some kind of assistance when he walks in a uneven terrain or performing a kind of a dual task. So someone's balance capacity requires supervision or some kind of a manual assistance, use a work balance scale. Otherwise, use mini bus test all the times. The work balance scale is used alongside the mini bus test when someone scores FAT score of below 3. Right. What if someone who score functional ambulatory category stage beyond 3, which means the person can walk independently, require a supervision, that is the category of 4. 5 is can walk independently outdoor. So then use these scales, these measurements. So 10-meter walk test, that is used to measure the walking speed. 6-minute walk test is recommended when you want to test the walking endurance. Right. The dynamic gait index you can use for testing a complex walking. I'm just giving an example from a stroke scenario. This is basically to throw light on when to use an outcome measure. What outcome measure to use? And by using what these outcome measures, what you basically identify. So we need to know, we need to understand this. 10-meter walk test we are familiar with, but we need to know how to use this. There are different ways of reporting this 10-meter walk test. Some trials say 10-meter walk test where you consider 2-meter acceleration and 8-meter walkway and then 2-meter deceleration. But ideally, you have to have 10 plus 2 plus 2. Then you have to have 14-meter walkway where you measure the walking speed in the middle 10 meter. That is what recommended. And you should conduct 3 trials and take an average of it. Whenever the patient is wearing a walking aid, using an assistive aid or a walking aid, then you have to let the patient to use during pre-test and post-test. And then 6-minute walk test, you need to have 30-meter corridor. The patient should walk within that corridor for 6 minutes. So there are guidelines given. When you want to do a complex walking, then use dynamic gait index. So every measure has some kind of values, when to use, what you look into it. So this is very important. See, for an instance of work balance scale, we know about the work balance scale. What is the effect size of work balance scale? Effect size means, or in another word, you can say MDC, minimum detectable change in the work balance scale. Minimum detectable change is nothing but a smallest amount of change in a measurement. Here it is the work balance scale. That is not attributed to the measurement error. We are not taking the measurement error into an account. So the change that you see in a patient in a work balance scale for 4 weeks or 6 weeks is not by chance. It is not happened just like that, not by a spontaneous recovery. So it is by the influence of a rehabilitation. And you think that way, it is influence of physiotherapy treatment, then that is the MDC, a minimum detectable change. So need to see that how much of the change in work balance scale is reliable. Reliable means it is meaningful to you as a clinician or as a researcher. So that is the MDC, right? And then something comes about MCID. MCID, there is a small difference between MCID and MDC. Contrary to MDC, MCID is the smallest amount of change in an outcome measure that is clinically meaningful or relevant to the therapist or to the patient. See, for an example of having a intervention study, you have two groups. One group is an experimental group, other group is a control group. Experimental group produces 6-point changes after an intervention. The control group produces 4-point changes after an intervention. The difference between this mean change between these two groups is 2 points. So the 2-point change is clinically relevant. Suppose you think you conduct an intervention having a control group and an experimental group. As a clinician, given a dosage, you think there will be 2-point mean difference between the groups that is clinically relevant. For an example of work balance scale, the 4-point change is clinically accepted. So it is an established scale, difference in a stroke trial. Then suppose you conduct an intervention, then you have to see to that your new intervention also should be able to produce 4-point change or beyond that compared to the control group. That is what the clinically relevant. If a new methodology is producing less than that, then nobody would want to use that particular methodology or an intervention methodology. It is not that you cannot use, but the given dosage is insufficient to produce that much of meaningful change. That's what you need to understand it, right? So here comes about an effect size. Basically, this outcome measure is particularly used in an intervention studies or an observational studies. The commonly just we come up with this effect size. What is this? Effect size is nothing but how meaningful the relationship between these two variables. That's what I said as strength of association. It is measured in R, Pearson correlation, or the difference between the two groups. That is the mean difference between these two groups. That is measured in Cohen's d. So that is the effect size. There is a value that you can refer elsewhere. In an intervention studies, Cohen's d 0.2 is small, 0.5 is medium, 0.8 and above is large effect size. Whereas Pearson correlation is measured between -1 and +1. Anything close to this minus and +1 has a poor strength of association, and anything falls between has a moderate to good association. And in a correlation studies, when you use an outcome measures, when you find a relationship between a strength of an association between two variables that is measured in R, then see the predictive value. Sometimes it's said that positive predictive value or negative predictive value. When two variables are increasing or two variables are decreasing, then you have a positive predictive value. If one value is increasing, other value is decreasing. For an example of strength gains, the pain decreases. So both are, the strength gains is good, pain reduction is good. So you will have a negative prediction value. So when you use this outcome measures, consider this. And very importantly, use of outcome measures is of an importance when you conduct intervention studies, particularly PhDs, postgraduates. When you pick up intervention studies, you are asked to calculate a sample size. So to calculate a sample size, what is required is prevalence estimate, event rate, mean standard deviation, or size, sample size from already published small studies are required. So certain ideas I give before I conclude my talk. Sometimes we say sample size calculation we say a parent article and we pick up the sample size from an already published article. But that is not ideal, because you can pick up a sample size from an already published article, but you need to have a same interventional methodology, similar interventional methodology with a similar outcome. That is what very important. So sample size is determined based on a primary outcome measure that you choose. So in this primary outcome measure, how much of change over 6 weeks is clinically relevant to you, that you have to say. That change, based on the change only, you can calculate the sample size. The change, that is standard mean and standard deviation. So with the mean, standard deviation, you can calculate the effect size. You cannot pull out some article and you can't say this is the sample size. In an intervention study, to calculate the sample size in a primary outcome measure of your interest, then you need to have a mean and standard deviation of that measure. For that is the reason why we recommend you to do a pilot study, a preliminary study. So you take a set of a small sample and you conduct an X intervention of your interest and see how much of change is there. So based on that mean and standard deviation, you can calculate a sample size for a future randomized controlled trial. That is the dissertation conducted in a doctoral studies. To do that, to see, to estimate this much of an effect size, you have the duration, intensity, dose. I will treat the patient 45 minutes in a day. I treat this particular patient for 3 weeks. In each week, I will treat for 3 days. So that means what? 1 hour a day or 45 minutes a day, 3 to 4 weeks, 3 to 4 sessions a week, 3 weeks. Then 3 into 4, 12. So then you need to treat 12 sessions. Suppose you treat that particular patient 12 treatment sessions with the dosage, with the sufficient intensity, and you have a sample of this much, then you expect this much of change in the outcome measures of your interest. That is how you do a hypothesis test. It is not that you say arbitrarily 25 patients in an experimental group, 25 patients in a control group, and you will recruit a patient, first patient, you take an outcome measure, the second day patient will come, third day patient will not come, you tell the patient to do something at a home, then the patient will come later and you take an outcome measure. Where is the dose? Where is the dosage? To test the hypothesis, to say this much of change that you will have, right? You cannot do that. So you have 4 patients, that much only you have done, and you don't meet a sample size, and the 4 they becomes 40, then it is not the research, it is not the randomized controlled trial. With that outcome measure, we cannot determine anything. We cannot determine the effect size. We cannot determine the MDC. So this is very, very critical, right? So you pick up a outcome measure that has a responsiveness, but you are not following up a methodology. But whatever the change that you have obtained is not real. It is not real. Then you are not testing the hypothesis. So this one we have to remember. So whenever we do a sample size calculation, we need to consider how much of mean change and the standard deviation is anticipated. If standard deviation is less, then the error is less, right? The error is less. If the standard deviation is more, then the number needed to treat should be more, right? The error becomes more. So this is a very important aspect that you have to consider. So that is where we have a hypothesis testing. So sometimes we happen to see many hypothesis testing. Hypothesis one, your study cannot have multiple hypotheses. You have one hypothesis, null hypothesis. That means an experimental group is not superior over control group in improving the X outcome measure after this many duration of time. That is what the meaning. So which means it is not about an experimental group is not superior over a control group. You are having a primary outcome measure. The experimental group is not producing a statistical significant differences in an X outcome measure over the control group. That is what a null hypothesis. The alternative hypothesis is something, the experimental group is superior over control group in producing the beneficial changes on an X outcome measure. So that's what about hypothesis testing. You have one null hypothesis and one alternative hypothesis. So in a research, you will have this kind of an error. We commonly see this type 1 and type 2 error. See, the type 1 error is something where null hypothesis rejected, where actually it is true. Right? That is what about type 1 error. And the type 2 error is something about false negative, where no, you accept when actually there is no true difference, right? So it's something like in a simple word we need to put it across. In a cricket, umpire is given not out to a batsman, but actually he is not out. Then it's you are accepting a null hypothesis, but he is out basically, but umpire has given a not out. So that is a kind of a type 2 error. In other instances, he is out, but umpire is giving a decision of not out. So this is a kind of a type 1 error, a false positive error. So this we need to know. So to minimize this kind of type 1, type 2 error, you have the level of significance. So that is that is a p-value 0.05, and you fix the power 80% power of a study. 80% power of study means it is basically a level of 20% chance of false negative, right? So these are the things that is not changed. You fix at the beginning of the study. The p-value you fix, a power you fix, and you take the mean and standard deviation. The standard deviation is the numerator, and the mean difference is the denominator. So the sample size change is based on the clinically meaningful change that you anticipate. Right? That's how the sample size is calculated. It is not arbitrarily calculated, based on drawing from a previous study. As a clinician, we need to determine. We need to determine how much of change is clinically relevant. So the sample size is calculated either using mean standard deviation or an effect size. Sometimes you use Prairie sample method, GPAR statistic. There are so many statistical softwares available. Then you fix an effect size of 0.6 that is accepted, 80% power, and the alpha error, the level of significance 0.05. Then the required sample size would be 65. So it is constant. But you cannot have every time the 0.6, then the number also will be 65. So we have to determine how much of change in the specific outcome measure is relevant. Okay, so this is basically to give an overview about the outcome measures. Why we should use an outcome measure? What outcome measure to use in a research or in a clinical practice? The next sessions will be mainly dealing with the specific outcome measures in a specific conditions. So as an introductory talk, just I have given you an outline about the outcome measures, who can use these outcome measures, when to use outcome measures, what as when a clinician or a physical therapist or researcher should consider while using an outcome measures, in what are the research we use commonly use these outcome measures, and then what kind of a statistics that we approach to determine the MDC or MCAD or an effect size. These are some of the ideas that we need to have whenever we pick up a outcome measure. So thank you. I will conclude my talk with this. If you have any questions, I can take up a couple of questions.
Sir, I have a question. See, whenever we use lot of outcome measures and there are not context specific to us actually. So I feel that there are certain items which are not relevant to Indian context as well as cultural specific. So I
Right.
feel that we need to focus on developing our own outcome measures with all these factors into consideration.
Yes, true. Right. So that's what it is very valid. The question is some of the outcome measures are developed in a Western country specific to their context. So when we use those outcome measures, it's not relevant to our population. So that is the case. We need to we need to come up with an outcome measure that is specific to our community. That's the another kind of a research tool development. Yes, true. What you said is true, right? But most of the outcome measures, other than the functioning measures or a quality of life measures, can be applicable because they address at the body structure and function level. They are well established. That can be used definitely. Right, and there are a lot of questions in the text box. See, some of the questions are about sample size calculation, hypothesis testing, error, how to calculate sample size based on error, standard error, standard deviation. Okay, fine. Okay, right. So as I said before, I'll just say explain this particular thing. How to calculate a sample size based on standard deviation of the primary outcomes. Right. Right. What is standard deviation? It is the dispersion. If you have a measure of central tendency, you have a mean. You take 20 sample, and how the values fall of this 20 sample. If you have a homogeneous population, and then all of them scores will fall close to the central tendency. Suppose you don't have a homogeneous population, then every value will be different. For an instance of verbal, and somebody scored 10 points, somebody scored 40 points, then the mean is not not similar among all those 20 subjects. So the standard deviation becomes more. Now imagine about the sample size calculation formula 2, and then you have in bracket you keep a plus b whole square and standard deviation whole square divided by mean whole square. What this a and b says, that is about the level of significance and power, that will not change. But the standard deviation is wider. What happens? It's in the numerator, and the sample size required also will be more. So that is the reason why you have a stringent criteria for randomization. So you should not violate a randomization has a procedure, right? So you have to have a stringent randomization procedure so that the population will have a homogeneity, or the variables that you choose will have a homogeneity, right? So that is what homogeneous of variable you test with the Wilks test. And when you have two groups, the baseline characteristics of that particular outcome between two groups will be similar. Then you can run a parametric test. You cannot do that, right? So this is one rule that you need to consider. And the other aspect is that how long you are going to treat and what concept that you take, and you treat for this many duration of time, how much of the change that you anticipated. For an example of trunk impairment scale you take. Trunk impairment scale produces 4-point changes. You think that way. And the standard deviation is 2 points, then the number needed to treat should be less. Suppose you think this difference is 4 point and standard deviation is also 4 points, then you don't have a homogeneous population. then the number needed to treat should be more. So the sample size calculation is determined based on what outcome that you choose and how much of change that you anticipated in the sample. When you have a sample, then of course you will have a standard deviation. This is one way of doing this. I think I answered to that question. Now, any other question? I can take one more question, then I hand over the session to speak.
Sir, I have specific doubt on homogeneous population, sir. But if we going, if we are taking, if we take experimental control group, we can take both homogeneous and heterogeneous group, no, sir, for calculating standard deviation.
No, you should not take a heterogeneous group. That is where, see, sometimes the population, suppose we say population stroke patient. Right? But actually population is not a stroke patient. We have to define the population. It could be an ambulatory stroke patient. The population of interest is walking patients, right? Ambulatory patient. The definition of population is stroke patients. Then who are they? Because the chronic stroke patients would change to an extent. An acute stroke patient would change in a different extent. So when we say population, ambulatory chronic stroke patients, 6 months post-stroke patients, then the population is different. Same way, we have a stringent criterion, inclusion criteria, exclusion criteria, right? So you have an inclusion criteria, exclusion criteria, then you have a homogeneous population. This population, you are dividing them into two groups, which means the patient comes to you with a criteria, with a walking ability. You screen the patient, and the patient meets the criterion of an inclusion or an exclusion, then the particular patient has an equal chance to get allocated into any one of those two groups. We cannot randomly select. Okay, this patient will go to experimental group, this patient will not improve, so he will go to a control group. Or I cannot treat the patient, he will go home, I will put him in a control group. Then we are violating the randomization. Right? So that is the case, the homogeneity will be ensured. Follow strict randomized control norms will be ensured. We will not have a heterogeneous population.
Sir, in descriptive study, we can use this criteria, no, sir. We can even use Prisma type, no, sir. Prisma.
Prisma is a different chart actually. Descriptive studies are different. Of course,
Okay.
Descriptive studies where you select again a population and you pick up the variables and you report the variables as it is, right? So even in a walking patient, you take the walking patient and report that this is the walking ability. That's it. So it gives a mean standard deviation or a proportion. But you take another variable and you start correlating that, then you use a different statistics. So only thing, you are not testing a hypothesis in a descriptive study. You are generating hypothesis. It gives you a causal relations between the strength of association. Suppose you want to predict what variable would determine something, then you have to have multiple variables and the dependent variable, and there is a different way of examining and conducting. Right. Prisma is a chart.
Sir, how can we make scale reliable for descriptive studies, sir? Which scales are more reliable? How can I choose scales that are reliable for descriptive study?
Descriptive studies, the scale is reliable, of course, but what you have to see is in that particular population, it is valid. That's what we have to see, right? The reliability is already established. If the reliability is questioned, having an established scale, then what comes is measurement error, because we don't know how to take the scale and how to administer that scale. So the issue is not about the reliability. Ensuring that the measurement error is taken care, the scale is reliable. What we need to see is whether that particular scale measures the intended construct. That is where we say whether this particular scale is validated in a stroke. It may be validated, and we have to cross-check whether it is validated in TB. We cannot use it just like that. So, while picking up a scale, what we need to see is whether it is valid in a population. Of course, we need to see whether the tool has a responsiveness to pick up the change. Right? The tool responsiveness means how well the tool can pick up the actual changes happening in a patient. If the tool doesn't have a responsiveness, the patient may improve, but the tool may not be ideal enough to pick up the change, then it is of no use. So the choice of selecting the tool in a clinical research or a practice depends on understanding about the psychometric properties of the tool. That's where I said for a balance, I explained about a construct. It can be steady state, it can be forward reach test, it can be verbal escape, it can be Trinity Poma, it can be mini bus test, it can be bus test. So there are different things. But it depends on the knowledge that we have about the outcome tool, and our clinical judgment and rationale also comes to it.
Sir, we can use this for a short time, like a 2 month study or a 3 month study. Is it reliable?
Yes, exactly. It is not reliable. We should not use the term reliable. We can use, definitely. It's about an applicability of a tool. We can use. But what for you are using, that we have to say. See, we are using this particular scale, whether the scale picks up the changes, right? Because you treat a patient, you try to change some construct, right? You give an intervention, a strength intervention, the strength will change. So a measurement should be able to pick up the strength. The MRC grade will not pick up that. It is not sensitive enough to pick up the changes. Of course, you have to have a dynamometry to pick up the changes. When the dynamometry is sensitive enough to pick up the changes, then you can test the intervention effects. If you use an MRC grade, it is not sensitive. In that way, any tool can be used, but we need to be judgmental to see its applicability and what for use at school.
My question, sir,
Yes, please.
if a researcher is conducting a pilot study, if he's not achieving the desired result, he can go with that larger study, or he has to stop, or he have to change the study.
Right. Okay. Good question. Yeah, the question is, if you don't expect a desired research, whether you stop the work or you go ahead with the other one.
In case of a person who is doing PhD thesis, if he conducting a sample size of 10 sample size, if he is not achieving the desired result, he can go with the study, or he have to continue other topics like that. I'm asking.
Right. Okay. Good question. Right. So the pilot study or otherwise feasibility studies conducted for two reasons. One reason is about to determine a sample size for a future randomized control trial. Usually in a doctoral thesis, you do that. And other thing is to look for a feasibility, that is whether this intervention produces any adverse effect, right? Whether it produces harmful effect, any discomfort to the patient. Then you try to change the methodology. You need not to change the study per se, you change the methodology, right? So that's one. And the sample size what you would take, right? It's based on a hypothesis testing. Suppose you are doing a superiority trial, and you think that experimental group is producing will produce more changes than a control group. It is a superior trial. Sometimes there can be a non-superiority or inferior trial, where you try to compare experimental intervention with a already established standalone treatment. They also improve. Then the between group changes will not be as you anticipate. So that means the hypothesis will be different. A new intervention also would produce a similar effect as to already established. So it's a different thing, right? Yeah.
Tell me something about bias, research bias.
Right. Okay. Now I think we are running short of time already. 3:20.
Just a few words. Sir.
Next topic.
Yeah. No. Maybe you can text it, and we will reply through messages. Right.
Okay, okay,
Fine.
thank
Oh,
you.
okay. The next speak, because otherwise we will run short of time, lagging behind time. Yeah. Nirmal, I will explain to you. I will just reply to you. Thank you.
Thank you so much, Dr. Karthi Babu sir, for your insights and your knowledge sharing with us. And our next talk, we are also fortunate to introduce our next speaker, Dr. Venugopal K, MPhil PhD, Professor KMCH College of Physiotherapy, to deliver a talk on type of outcome measures and psychometric properties. Over to you, sir.
So good afternoon, one and all. Today, the current topic focused on the types of outcome measures and the psychometric properties. Before proceed in detail about this topic, first one is outcome measures is nothing but the variable. The variable, which I would say it is a variable. A number of variables are there, which will be discussed one by one. So, outcome measures are nothing but variables, which is something is subject to change. So it has more than two values also. The value of one variable can influence the value of another variable. Sometimes other variable, which is hidden in, has its equal impact on the dependent variable. In equal impact on the individual and the outcome. For example, these three things will be mainly focused in any research. So, also the psychometric properties like validity, reliability, norm will be focused. So first we'll start with variables. Variables are nothing but having a nature of varying. So a variable is having more than one value. For example, height or time, it may differ, and height also differ from person to person. So a variable is having a measurable characteristic. It may change from person to person, or from group to group, or even within a person over a period of time. So variable refers to the factor or condition that can change during the course of an experiment. So what we are assessing previously, in due course of time, that may be differing. So the values of variables can differ at different times for the same subject or an object. For example, height, blood pressure, heart rate, what we are measuring now, after half an hour, we are taking the measurement of BP, it may be different, okay, like that. Yeah. So types of variables, first one is independent variable. So independent variable is manipulated by the exponent. It is having a capacity of influencing another variable, and also it brings the changes. Independent variable is the condition which we can change or control in experiment. So its value will not be affected by the value of other variable. For example, so the income of an individual, which affect the expenses of him. So in PT, the fall of an individual will lead to tissue damage. So we may experience pain or swelling. So it is also called as manipulative variable. So it can be manipulated by the experiment. So that is, we can change the value of the variable. For example, ultrasound. For example, ultrasound therapy, the duration may be modified according to the necessity of the treatment, 10 minutes, 15 minutes, 20 minutes, so on, or seriousness of the disease condition. Non-manipulated, it is also having a pre-existing character, which we cannot directly manipulate, but we can select based on the pre-existing character. For example, age, weight, biological function, pain perception, etc. So independent variable also be called as or known as causal variable. Next, dependent variable. It is the presumed effect. So a variable which is affected by the manipulated variable or independent variable. It is also known as outcome variable or predicted variable. So it is normally affected by another variable in order to bring the changes. So its value will affect the other variables' value. For example, income, which will affect our expenses, and also falling of an individual may lead to tissue damage, and he may experience pain or swelling. So that is dependent variable. So dependent variable is simply called as effect variable also. Then mediative variable. On the surface between the time the independent variables start operating to influence the dependent variable. So on the time their impact is felt on. So for example, so that will be explained in the next slide. Intervening variables are caused by the independent variable, and which will cause the dependent variable. So it explains a causal link between the independent and the dependent variable. For example, when you are offering IFT in order to relieve pain in an individual, the intervening variable may be self-confidence. So when he is possessing self-confidence, that will also help him to come out of the pain. And also ultrasound in order to give a relief and also to improve the health. And when the person possesses immunity, which is very higher, so that will also act as an intervening variable. So that will give him a pain relief, and also his health will be improved. So nature of the measurement consists of 4 different scales. First one is nominal scale. It is also called as or referred as categorical variable. Categorical scale. It has no numerical or quantitative properties. Categorical variables are labeling the variables into different categories. For example, gender, locality, language, marital status, married or unmarried, educated or uneducated, like that. So numerical values may be given but do not have any mathematical meaning. So the nominal scale it acts as a label, and its changing order does not have any significance. For example, demographic data in a questionnaire, you will ask what is your gender, male or female, which language you are speaking, rural, urban background, income level, etc. Then ordinal scale. It is also known as ranking scale. So ordinal measurements it consists of an ordered set of categories. So it is normally telling you about the direction of difference between two individuals. So the scores are given in such a manner that the number increases, the status condition also increases or upgrades. The numbers are assigned to variables in order to represent the rank or relative position. So variables are arranged in a specific order. For example, take from the school level, 10th standard, +2, UG, PG, etc. So then also about pain. How often do you feel about the back pain? No pain, 0, mild pain 1, moderate 2, then severe 3, like that. Interval scale. So interval scales are having equal distance or equally divided, but there is no absolute 0. Only arbitrary 0 is available in the interval scale. So And also it is allowing the researcher to allow some mathematical operations so that like standard deviation and mean can be calculated. For example, like a scale. So supposing we are having the opinion from an individual, so the 5-point scale, 7-point scale, 3-point scales are there, even 2-point scales are there, but 2-point scales are not normally considered. 3-point, 4-point, 5-point scales are there. So the example quoted regarding what is the anxiety level or what I think. Yeah. What is your opinion about allowing youngsters to join in Indian Army? So strongly agree, neither agree nor disagree, strongly disagree. So this is the 5-point scale. So the scores may start from 5, 4, 3, 2, 1, or 1, 2, 3, 4, 5 like that. Then ratio scale. So ratio scale overcomes the disadvantages of all the scale, especially the interval scale. It consists of actual 0 point, which represents the absence of a measurement, and also it gives a meaningful measurement. So it measures in terms of equal intervals and an absolute 0 point of origin. 0 point tells about the absence, and other values are telling about the presence of the values. So it is having all the properties of nominal, ordinal, and interval scales. So the biophysiological characteristics like age, height, weight are examples. So the variables that are measured either in an interval or ratio are considered as continuous variable. Example, it can easily be stated that a person with 80 kilogram weight is twice heavy as someone who is having a weight of 40 kilograms. Right. Then psychometric properties. So intrinsic components of a test and reveal information about a test adequacy, relevance, usefulness, validity, reliability, and norming. Stability of measures. First of all, reliability. So reliability means consistency of the scores. Consistency or stability of a measure by reliable. Same reading on a particular individual when repeated for one or more time. Test retest reliability, parallel form, split off, then Spearman-Brown prophecy formula, Cronbach's alpha, inter-rater reliability like that. Test retest reliability. So we are applying the same scale to same respondent, 2 different periods of time under the same condition. Parallel form. It consists of 2 similar sets of measures. High correlation with both the forms are possessing have similar item and same response format. So the changes in the wordings and the order of questions are there. Then split off method. So items on a scale are split into 2 groups, first half and second half, and scored independently. Scores on the 2 offsets then are used to compute a correlation coefficient. For example, 50 items in a tool, x is equal to 1 to 25, and y is equal to 26 to 50. Odd and even. So item on a scale are split into 2 groups, that is odd number of items and even number of items. Then the correlation coefficient is calculated. Scores on the 2 offsets then are used to compute a correlation coefficient. After that, the Spearman-Brown prophecy formula is applied. R is equal to 2R divided by 1 plus R, where R refers the correlation coefficient. Then Cronbach's alpha, it is also same as the retest reliability. Split off method is followed. So here correlation is equal to K divided by K minus 1 into 1 minus sigma of standard deviation of Y divided by standard deviation of X. Now inter-rater reliability. So estimated by having 2 or more experienced or trained observers. So when they are watching the event time simultaneously and they are recording the events individually and according to the instructions on the instrument. So their number of agreements divided by number of agreements plus disagreements. Validity. So it is the degree to which an instrument measures what it is supposed to measure. For example, so the instrument to measure DOS, Big Five, self-esteem, self-efficacy, etc. Face validity. Face validity appears as though it is measuring the appropriate construct. For example, the English, Tamil, Malayalam, Telugu, okay, translated version. Then content validity. It is the degree to which an instrument has an appropriate sample of items for construct being measured. So by scale and dash scale. These are all psychological scale type. Criterion related validity, which determines the relations between an instrument and an external criterion. For example, an individual who scores high in entrance exam will do better in college than those who score low on entrance. Predictability. So it is the adequacy of an instrument in differentiating between people's performance behavior on some feature criterion. Construct validity. So this instrument really measuring, does it equally measure the concept of interest? So it measures for what purpose the instrument is constructed. Thank you. Any questions?
Sir, I have doubt.
Tell me.
Sir, I have doubt in about validity skills, sir.
What is that?
Validity skills.
Validity.
Validity. Validity, sir. About predictive validity, sir. Predictive validity. I didn't understand about that, sir.
Predictive validity, yeah.
Yes, sir.
So, hold on.
About predictive validity, sir.
Hold on. We'll come back.
Okay.
Validity. So, how people are behaving or performing, okay, so which will differentiate the present with the feature. It will have some other criterion. Based on that validity can be applied, predictive validity. May I answer your query?
Yes, sir. And I have another doubt in Cronbach's alpha test, sir. Cronbach alpha. Cronbach's alpha.
Yeah, that is with the help of split off method, we are applying the values in the formula. R is equal to K by K minus 1 into 1 minus sigma of standard deviation Y divided by standard deviation X. So when you are having the value, when you are coming and step by step doing the calculation, you can able to understand.
Okay, sir.
Yeah. Any other query?
No problem, sir. No problems.
Right. Thank you.
If you have any doubt, you can put in the chat box. We will answer you.
Where we can use this Cronbach's alpha and iterator scale, sir?
No, it is a tool. I mean, it's a statistical pack.
Yes,
in order to measure the validity of an instrument. Like split off method, no.
Sure.
Splitted the even number or odd number That is the best method. Instead of dividing into 1 to 25, 26 to 50, dividing even values and often values, then doing the correlation coefficient calculation. After that, that value should be applied in the formula. 2R, 2 into R means 2 into correlation divided by 1 plus correlation. So that will helping us to know about the content validity of an instrument.
Is this more reliable than mean, median, or standard deviation like scales, sir?
So mean, median, standard deviation scales are different. This is very different, okay. Because whenever the correlation value is plus 0.70, the reliability validity is more. Okay. And if it is less than 0.50 or less than 0.50, so reliability is considered as very poor.
Sir, 1 minute. Come again, sir. I didn't get in, sir. I will just write it.
Regarding
Write
what?
it.
Regarding what?
And about that scale, sir. What you just said about that variables.
Calculation.
Yeah.
Split off method. No, split off method means we are collecting the data. Even number of data is pulled into one group. Odd number of values are pulled into one group. Then the correlation coefficient is performed. All Pearson's correlation coefficient. After doing that, we are applying the formula Spearman-Brown's test. Okay. That formula is 2 into R, 2 into correlation divided by 1 plus correlation. So the value which you are getting, that will determine. So as I told, if the value is more than plus 0.70, the consistency is more. Okay?
Yes, sir. If less, consistency is less.
Yeah, if it is less than 0.50 or 0.50, consistency is there, but it is very less.
Okay, sir. Noted down, sir.
Right.
Thank you, sir.
Thank you.
Good evening, sir.
Tell me.
Sir, if we would like to, run or read about a device, reliability and validity, so do we need to go through all these scales, whatever you mentioned, like Cronbach's alpha, different types of validity you have mentioned. So ideally, what are the things we need to, if we want to do some reliability and validity study, can you just brief the procedure, what we need to do? Or what are the things we need to take?
To know about the reliability.
Yes, sir. Reliability and validity of any device if I want to find out. If I want to do a study regarding reliability and validity, so how should I perform it, sir?
You have to perform correlation coefficient.
Okay. And
I
further
told
we
you,
need to take,
the odd number of scores, even number of scores are bifurcated.
Okay,
Then you have to calculate the correlation coefficient, Pearson's correlation coefficient. After calculating Pearson's correlation coefficient, the value should be applied in the formula. That Spearman's Brown, that test split off method. That formula is 2 into correlation, 2R divided by 1 plus R. 1 plus R means 1 plus correlation. So that will give you the value.
Okay, sir. Thank you, sir.
Any other queries?
Thank you, everyone. And dear participants, thank you for your practical questions and beautiful interactions with speakers. And today we will signing off the session. And tomorrow we will start the session at 2 o'clock. Since today, few technical glitches, we couldn't start at the right time. Tomorrow onwards, we'll be starting at 2 o'clock. And whoever not filled the pre-test questions, and please answer it. And thank you for your participation.